Endocrinologist and diabetologist, and currently I'm working at Kovai Medical Center Hospital in Coimbatore. And today we have with us Dr. John Ayuk. He's a consultant endocrinologist at University Hospital Birmingham, England. And we also have with us Dr. Suresh Damodharan. He's a consultant diabetologist and endocrinologist at Sri Ramakrishna Hospital, Coimbatore in Tamil Nadu. So, Dr. Ayuk, I have trained with you in England a few years ago before moving to India to settle down. So, could you please tell us your field of interest in endocrinology and what you do on a daily basis?
So, my general interest is what you might term endocrine oncology. So, tumors associated with endocrine organs. So, as you know, I lead the pituitary service in Birmingham. I also run a multiple endocrine neoplasia type 1 clinic, and I'm the endocrine lead in our neuroendocrine tumor service. Along with that, I also manage a part of the NDT, or multidisciplinary team, for management of pheochromocytomas and paragangliomas.
Dr. Suresh Damodharan, do you have any special field of interest in endocrinology and diabetes?
Thanks for the opportunity. I think the main thing that is prevalent in our country as an epidemic is diabetes and thyroid disease. And my way of looking at it is, even though you get extensive training in various specialities, like what doctor was saying in pituitary disease or adrenal, but practically here in India, what I notice is plenty of opportunity to do better practice in the field of diabetes and thyroid disease. So I'm mainly focusing on that currently, just to do how to do a specialized care in diabetes and how to prevent complications, how to screen for the complications, and how to do a better quality of care in diabetes wise. And thyroid wise, it's mainly education and also identifying the prevalence and helping the risk people and managing the thyroid disease in pregnancy, which a lot of cases are managed what it shouldn't be managed. So this is my way of approach in India, but the field of interest is one can have a field of interest, and I have to say pituitary was my field of interest for a very long time. But I think currently my main focus is in giving high quality care in diabetes and thyroid disease.
Okay, and we both trained in England before coming to India, and obviously you came a few years earlier than me. So how different do you think is endocrinology, the way you practice in England and in India?
There is quite a few differences that is very, very obvious, and there are quite few differences which is very subtle. And I think the obvious differences is probably start with not endocrinology as a whole, but being a doctor as a whole. I would say the communication, and I think in the Western world what we trained in, the main thing is communication, and whatever I learned and whatever I do, I just communicate with my patient, and that could be better in India, and that is the way that I practice so that my patients get the maximum benefit. So that is one of the major difference, I would say, from as a doctor perspective. But as an endocrinologist, I think a multidisciplinary team approach in England in an ideal scenario is the way we all got trained, with a diabetic nurse and an educator and a chiropodist and you name it, an endocrine nurse who can do all the insulin tolerance test and IPSS, everything they can be of help with you. But here I think sometimes you have to pull up your sleeves and work on your own, and sometimes that you will have plenty of help who you need to train them, and that can't be a difficult job if you have a system created for yourself, but it can be a difficult job if you don't have a system, and that is a challenge. So this is the general point of view as a doctor and endocrine point of view.
Dr. Ayuk, and in India, do you think the endocrine conditions are, one is a late presentation, or they get missed until they're a bit advanced?
I suppose you're better placed to answer that question than me because you've practiced both in the UK and in India. But as you know, I know you were asking in particular reference to pituitary disease. Pituitary disease tends, most of the disease will present as tumors, pituitary tumors. And the majority of pituitary tumors will be non-functioning tumors, which again, as you both know, will often not cause any symptoms and are often picked up incidentally when people are being investigated for other symptoms for other conditions. I don't think there's any way of improving early detection for those sorts of tumors. Functioning tumors is a different matter because functioning tumors will often cause symptoms. And for example, the published literature will tell you that acromegaly, for example, the lag time from the beginning of symptoms to diagnosis is usually anywhere between 7 and 10 years. So patients have symptoms for many years before the diagnosis is made. And that's because the hormones act on many different systems in the body, no one puts 2 and 2 together. And it's a similar picture with Cushing's disease as well, because that causes symptoms, all sorts of symptoms, and people often will treat the individual symptoms but not put it all together. Premenopausal women are probably the group in which we are able to pick up pituitary disease earliest, and that's because women are very fortunate to have something which is very sensitive to any sort of endocrine misbalance, and that is the periods. So usually the first thing which goes in a woman is periods, and so it's important that people know that if a woman has been amenorrheic for 3 to 6 months, you need to start thinking about reasons why she's amenorrheic, and part of that will involve hormonal analysis, and that way we can pick pituitary disease up quicker.
So I picked from what you said. I mean, I was just thinking in India is an excellent place, excellent place for the volume of disease, and especially the pituitary disease. I've seen some fascinating cases here. But as you rightly said, the challenge is just identification, and sometimes things can get over-investigated and sometimes under-investigated. So over-investigated, there is an opportunity to pick up some non-functioning ones, and sometimes you get a empty cell syndrome of the pituitary, and people just don't do anything with it. So there is plenty of area for opportunity for education in that area, whether how to open up the eyes and just do the screening for it, because a lot of cases go undiagnosed, I would say, and there is a blood pressure drop and there is an empty cellar, both people don't put together, So so my point is, I think because of plenty of opportunity in India, there is a huge potential for all of us who are working here, who can be the educators. But for 1 billion of people, we are talking about 400, 500 endocrinologists. I think we just need to have more trained ones, and that is our issue here. So if you got more people from India training in UK, please send them here.
Send them back to you.
Yeah, that's the way I could say. But anyway.
Can I just ask, Suresh?
Yeah.
I see you've got an Ethicon T-shirt on.
That's right. Yeah.
What's that about?
Well, I bribed few people to get it. Anyway, it is a new thing that we started in a CAD meeting in Mumbai. That is like debating ourselves, a contemporary debate. Within 3 minutes, you come up with the science, and your topic will be given to you. You come with the science in front of 300, 400 people without seeing a paper, nothing, no screen, no visual aids will be there. You have to talk some science. It's a bit fun, but it can be a bit nervous. The adrenaline will take you somewhere. So we started initially in CAD meeting in Mumbai, and then Diacon in Ahmedabad. We were talking about that meeting a few minutes ago. That's a month ago it happened, and this is the third one. and it's got more endocrine flavor to it. I really enjoy it. It just puts you in really in a hot seat.
So what was today's debate about?
Today's debate about quite a lot of things. One of them is about vitamin D is a fraud in identifying that, and one of the other things is whether the cardiovascular trials, what we are doing for all the diabetic drugs, whether it's worth it or is it not needed at all, and estrogen therapy, whether it's needed for postmenopausal women or not. So it's quite a few interesting
topics. Yes.
But I would say, I think with the current climate, diabetic drugs and diabetic population in India, diabetic drugs getting investigated or over-investigated from cardiovascular point of view is the main topic that I would say. And as you know, that FDA has voted recently for or against cardiovascular, so they want to improve on that, because we're getting a 3-point MACE and we're just focusing on that. So we are proving non-inferiority, but whether giving any positive result or negative results, we will never get that, I think. So most of the drugs will be safe, it will come, and we'll get some subgroup analysis, and we're just going to spend a lot of money.
Okay.
But yeah, that's the science aspect, and that's the fun. So debating about it. So Vidya, now I would say I've just given my view about how the practice in India, and I've seen plenty of opportunities, and I'm so happy that I made the decision to come back, and I can serve for my own people in a better way. Now, from women health point of view in endocrinology, what are the things that you see yourself doing in next 5 years that will that can improve the society, and also you can really feel that I've given something back to the community?
Okay, there are quite a few interests. One of my interests is osteoporosis. I know Dr. Ayuk is going to be pleased with that, because his special interest is in bone health. So I feel osteoporosis is not very well recognized as an endocrine entity in India. It's only when the patient breaks a bone that it gets fixed and is sent home, and there is no further investigation for osteoporosis, and people are not aware, and the doctors are not aware that there are medications to treat osteoporosis and prevent further fractures. So I would like to do more like a campaign for osteoporosis, start early detection and treating these patients, educate them regarding fracture prevention, and get rheumatologists and orthopedicians on board as well. So that is what I'm aiming to do, and I plan to do a camp in the month of December in our hospital at Kovai Medical Center. So where I will be screening the high-risk patients for osteoporosis, and there's going to be a meeting where I give a talk and invite the public for the meeting to educate. So, and that's one part of endocrinology that I want to make people more aware of. Another thing is polycystic ovarian syndrome. I know it's not Dr. Ayuk's favorite topic.
Oh, is that right? Well, I think the wrong place to be in India. We got plenty of them.
Yes. So again, it's down to obesity awareness that such an entity exists, and the treatment options. I would like to raise awareness about that. There's a lot that can be done for these young patients, because this can be one of the reasons for infertility and diabetes. Again, it comes down to lifestyle modification. So that is another area that I would like to work on. So at the moment, I've got 2 interests. Maybe these will change, and in 5 years' time, I don't know, I might have more things on my mind to do.
The second question I want to ask you is, in Europe, we got a luxury of National Health Service is taking care of our prescriptions. But coming back to India, you see a diabetic patient, there are plenty of drugs, sulfonylureas. You talk about metformin, sulfonylurea, even repaglinide, metaglinide, all these oglibos. All these drugs are available. How do you find that you want to give a right treatment to the patient and best treatment to the patient? On the other hand, the cost is a big challenge. So how do you address this issue? How you are addressing this issue, I would say, currently in your practice?
It was difficult first few months because I had not, I wouldn't say I never, I tried, I've used sulfonylurea maybe in a handful of patients in the last 14 years when I was training in England. But when I came here, that seemed to be the second line after metformin, and patients present to us a bit late with a HbA1c of 8, 10, as I've had the highest is more than 20. So at that point, it's difficult for me to, rationalize and say you'll be fine with just metformin, or you can just go with a DPP-4 or an SGLT2 or a GLP-1. Definitely, affordability is a major issue that does, I wouldn't say compromise the care, because sulfonylurea group is still a good group of medications, and it does work well in the Indian population. So I just I've learned to balance between making the right choice for the right patient and also affordability. So I do ask them, these are the drug choices and these are, better drugs. And the patient makes the choice, an informed decision. I want to try sulfonylurea first and then maybe try the others. So I do give them the choices, tell them which is the best thing, assess how much they can afford, and if they're able to afford, if they make the choice that they will want to try and metformin and then an SGLT2 or a DPP-4 or a GLP-1, then I offer it to them.
And there are some group of drugs, for example, alpha glucosidase inhibitors and insulin secretagogues, repaglinide and etaglynide. There are a few groups of drugs that seems to be less used in back in England. It is cheaper as well. So do you think there is a place that we can use these group of drugs as well somewhere? What I'm talking is, you mentioned about metformin and sulfonylurea, and we spoke about SGLT2 and gliptins and insulins. There is some group of drugs that has been in the cheaper version that has been underused, according to me, but I don't know.
Yes, they are being underused. One reason could be that there are simply better drugs. And the patients come in with a higher HbA1c. You don't want to use a weaker drug.
Sure.
So you want to use a drug that will give a better glycemic control rather than putting a patient on 2, 3, 4 drugs which are weaker. I would prefer metformin and sulfonylurea, or a metformin and a DPP-4 combination, which would help achieve the HbA1c that we want.
The reason I put up this question is a very important point, is because we treated a lot of patients with European background where the carbohydrate content what they've had is less compared to the carbohydrate load what we're having here morning, lunchtime and evening. So the drugs that is short acting insulin secretagogues according to what they eat, and then short acting glucosidase inhibitors will make sense in a lot of areas. But also the point you are making is multipolypharmacy may be an issue. But these are the drugs that can address the core issue in India, where I feel there is a role of these drugs. But
of course, there's a role for these drugs, but I think we should be concentrating more on decreasing the carb load in their diet rather
Sure.
than giving a medicine to do the job. I think we shouldn't be, depending upon a medicine to do the drug to do the job.
so
rather
when I
than we
try
should
to
be
do that, patient buggers off my clinic and goes to some other clinic. So that's a challenge, But yeah, I think they avoid the doctor. It's like a pigeon fancious lung. You say avoid the pigeons, and then they'll avoid you. So that's like that. But anyway, all right. Thank you.